Welcome to the Deep Dive. Today we're plunging into the remarkable world of your lungs. Think about it.
Yeah.
These tireless organs are constantly taking in the outside world with every single breath. But what happens when that crucial interaction goes awry?
It's a truly intricate question, because our respiratory health is profoundly shaped by such diverse factors.
Right.
We're talking about everything from our genetic code to the dusts we might encounter at work, and even the surprising impact of the animals we share our lives with.
That's right. So our mission in this deep dive is to explore a fascinating spectrum of lung conditions. We're going to guide you through some surprising connections, unique symptoms, and the subtle clues that help doctors diagnose these pulmonary challenges.
Yeah.
Our goal is to give you a clear understanding of conditions that might fly under the radar or have origins you'd simply never expect.
Exactly. You'll discover how specific environmental details or even our own biology can manifest in very distinct ways within your lungs, often telling a story that's, well, quite unexpected.
Okay, let's begin our exploration with two conditions that can be quite mysterious, and in one case, relentlessly progressive. We're talking about sarcoidosis and idiopathic pulmonary fibrosis. First up, sarcoidosis, which many call the Great Mimic. What makes it live up to that name?
It's earned that nickname because it can literally affect almost any organ in the body. I mean, at its core, sarcoidosis is an exaggerated immune response.
Okay.
Your body's T cells create these small clumps of inflammatory cells known as granulomas. Think of them like tiny, organized knots of immune cells forming unexpectedly in different tissues.
Little knots.
Yeah, and what's often perplexing is that it develops without a clear, identifiable cause. It's idiopathic in that sense, too, often.
So who tends to be most affected by this mysterious condition?
Well, it's observed more frequently in females, Black Americans, and Northern Europeans, typically appearing between, say, 20 to 40 years of age, though it can indeed affect individuals at any point in their life.
And since it's the Great Mimic, it doesn't just stick to the lungs, right? Where else might these granulomas appear, and what kind of symptoms do they cause?
Exactly. While over 90% of cases do involve the lungs presenting as maybe a dry cough, shortness of breath, or chest pain, it truly can spread.
Right.
You'll often see classic bilateral lymphadenopathy, which means swollen lymph nodes on both sides of your chest, visible on an X-ray. That's a big clue.
And this is where the mimic part gets really intriguing, because its reach extends far beyond the chest. What about the skin, or even more surprisingly, the eyes and heart?
Precisely. On the skin, you might see these tender red bumps called erythema nodosum, or sometimes a more common widespread rash. But the most distinctive skin finding is something called lupus pernio.
Lupus pernio.
Yeah, it appears as these purplish raised patches, typically on the face. For the eyes, a common issue is anterior uveitis inflammation in the front part of the eye. That can cause dry eyes, potentially impacting vision. And the heart involvement, well, that can be quite serious. It ranges from changes in how the heart muscle functions restrictive or dilated cardiomyopathy to irregular heart rhythms and even heart blocks.
And it can even impact the nervous system, which sounds incredibly complex.
It truly can. It might lead to issues with cranial nerves, like weakness of the facial muscles. The facial nerve is a common one, and even a rare condition called diabetes insipidus, which affects water balance in the body. It's a full-body challenge for diagnosis, really.
There's even a classic combination of symptoms that forms a specific syndrome, right? The Lofgren syndrome.
Yes, Lofgren syndrome is a recognizable triad. Erythema nodosum, those red skin bumps paired with the bilateral hilar lymphadenopathy we mentioned in the chest, and painful joint inflammation, often with a fever. It's a notable presentation.
Given its ability to appear almost anywhere, how do doctors begin to diagnose sarcoidosis? What's the initial approach?
Often the initial step is a chest X-ray, which can reveal those characteristic swollen lymph nodes in the chest. That's usually the best initial test.
Yeah.
But to be absolutely sure, the most accurate diagnosis comes from a tissue biopsy, where they look for those specific non-caseating granulomas, the non-cheesy kind.
Non-caseating, right?
Blood tests might also show elevated levels of ACE, an enzyme, and sometimes high calcium levels, hypercalcemia.
And what's the typical outlook for someone diagnosed with sarcoidosis? Does it always require aggressive treatment?
Surprisingly, not always. Many people who are asymptomatic, maybe it's found incidentally, actually see their condition resolve spontaneously within 2 years without any intervention. For those with symptoms, oral corticosteroids are usually the first-line treatment. Overall, the prognosis is generally good, with about 40% experiencing that spontaneous resolution.
But not always.
Not always. If it progresses to significant lung-scarring interstitial lung disease or presents with that lupus pernio skin finding, the outcomes can be less favorable.
Okay. From a condition that mimics many others, let's now turn to idiopathic pulmonary fibrosis, or IPF. The idiopathic part tells us the cause is unknown, which sounds daunting. What exactly is happening inside the lungs with IPF?
Yeah, daunting is a good word. With IPF, what we see is progressive, extensive scarring and remodeling of the lungs. The delicate lung tissue becomes stiff and thick, much like scar tissue elsewhere in the body.
Just gets harder.
It gets harder and harder to function. And you're right, the cause for this relentless process remains a frustrating mystery.
Are there specific risk factors for IPF, even if the primary cause is unknown?
Definitely. It primarily affects men over 50 years of age, and notably, cigarette smoking is the most strongly associated factor. It's a stark reminder of smoking's profound impact on lung health.
What are the typical symptoms someone might experience as this scarring progresses? Is it sudden?
No, it's usually gradual. Patients typically notice increasing shortness of breath over time, often accompanied by a persistent, non-productive cough. They might also experience general fatigue and unexplained weight loss.
And there's a really distinctive sound that doctors can hear with a stethoscope, isn't there?
Yes, what's fascinating here is the characteristic sound you can often hear on examination. It's described as diffuse, fine, dry crackles, particularly at the bottom of the lungs, especially when breathing in.
The Velcro sound.
Exactly, often described as sounding just like Velcro being pulled apart. You might also see clubbing of the fingers, where the fingertips and nails become noticeably widened and rounded.
Given how challenging it sounds, what's the preferred way to confirm IPF?
A high-resolution chest CT, or HRCT, is really the preferred imaging test. It typically shows a specific pattern called usual interstitial pneumonia, or UIP.
UIP.
Yeah, characterized by a reticular honeycombing pattern, where the lung tissue looks like a honeycomb or a dense net, most pronounced at the lung bases. This pattern helps distinguish it from other lung conditions.
This sounds like a very difficult diagnosis to receive. What's the reality for someone living with IPF?
It is. And, well, the grim reality is that there is currently no effective medical treatment that can stop its progression or reverse the damage.
No cure, then?
Not medically. It's a significant frontier where, despite advancements, the disease continues its relentless scarring. Most patients experience a gradual decline with a mean survival of only 3 to 7 years after diagnosis without intervention.
So a lung transplant is essentially the only true path to a cure.
Yes, a lung transplant is considered the only possible cure at this point. While some newer antifibrotic agents like pirfenidone and nintedanib exist, they really only aim to slow the disease's progression. They don't reverse it or cure it.
That's a profound reminder of the limits we sometimes face. But now let's shift our focus a bit to how our work environments can directly affect our lungs.
Absolutely.
This brings us to a whole category of conditions called the pneumoconiosis, which are essentially occupational lung hazards. Let's dive into silicosis, the threat of silica dust.
Right. Silicosis is a chronic fibrotic lung disease caused by inhaling silicon dioxide dust. It's a microscopic particle that, when breathed in over time, causes inflammation and scarring in the lungs.
What specific types of jobs put people at risk for silicosis?
Oh, several. Common exposures are found in occupations like coal mining, quarry work, sandblasting, the manufacturing of glass and cement, masonry, and even hydraulic fracturing or fracking.
And there's a really critical connection between silicosis and another significant health concern, isn't there?
Yes, a crucial point, really important to remember. Silicosis greatly increases the risk for tuberculosis. It's a major concern for anyone affected.
Wow. Okay. What does it look like on scans?
On imaging, like a chest x-ray, you often see multiple small round nodules, typically in the upper lobes of the lungs. Sometimes you see the classic but rare eggshell calcifications around the lymph nodes in the chest. Yeah, the calcium forms a thin layer around the node. And a high-resolution CT might even show a pattern called crazy paving, which looks like irregular lines in ground glass areas, kind of resembling an uneven cobblestone street.
So if someone is diagnosed with silicosis, what's the most important step in managing it?
The absolute mainstay of treatment is complete avoidance or minimization of any further exposure to silica dust. Plus, stringent use of respirators or other protective equipment. Preventing more damage is paramount.
Makes sense. Now, another form of occupational lung disease is coal workers' pneumoconiosis. often known as black lung disease. What's the cause here?
As the name suggests, this condition results directly from the inhalation and long-term deposition of coal dust particles in the lungs, leading to inflammation and scarring, similar in mechanism to silicosis, but with coal dust.
And there's a unique association with another common condition, something called Kaplan syndrome.
Yes, Kaplan syndrome is a distinctive combination. The presence of coal workers' pneumoconiosis alongside rheumatoid arthritis. It's an interesting overlap.
And visually.
Visually, well, a lung biopsy in these cases can actually show dark black lungs due to the significant accumulation of coal pigment within the lung tissue itself.
Okay. Next, let's look at berylliosis, which you mentioned can be thought of as a close industrial cousin to sarcoidosis. What's the connection again?
Berylliosis is indeed a granulomatous pulmonary disease, meaning it also forms those clumps of inflammatory cells, the granulomas, very similar to sarcoidosis. The key difference is that it's specifically caused by chronic exposure to beryllium.
Beryllium, the metal.
Yeah, a lightweight metal used in certain industries.
Which industries are those typically associated with beryllium exposure?
Industries like aerospace, high-technology electronics, ceramics, tool and die manufacturing, and even jewelry making carry a higher risk of exposure.
How do you specifically test for beryllium sensitivity and its effects? Is it like sarcoidosis testing?
It's different. The key test here is the blood beryllium lymphocyte proliferation test, or BEL-APT. That's the most appropriate initial diagnostic test for identifying if someone has become sensitized to beryllium. It looks at how specific white blood cells react to it.
And this condition isn't just about lung problems, is it? There's a serious long-term complication to be aware of.
Unfortunately, yes. Berylliosis is associated with an increased risk of lung, stomach, and colon cancer, highlighting the serious systemic impact these industrial exposures can have over time.
Now, here's a curious one. Biasnosis, often nicknamed Monday fever. What's the underlying cause and why the Monday connection? That sounds very specific.
It is very specific. Biasnosis is a lung disease caused by prolonged cotton exposure, typically seen in workers in the textile industry. The Monday fever phenomenon is its most distinctive symptom.
So what happens on Monday?
Patients experience symptoms like shortness of breath, wheezing, coughing, and chest tightness that tend to worsen dramatically at the beginning of the work week on Monday after being away over the weekend. Then the symptoms gradually improve later in the week or on the weekend.
So it's the re-exposure.
It's a direct link to re-exposure after that break.
Finally, in our occupational hazard section, we have asbestosis, a lasting and often tragic legacy of asbestos exposure. What exactly causes this, and how long does it take for symptoms to appear?
Asbestosis is a slow, progressive scarring, or fibrosis, of the lungs resulting from the inhalation of asbestos fibers. Crucially, symptoms typically emerge 15 to 20 years after lengthy exposure.
15 to 20 years.
Yes, this long latency period means the damage is often done long before symptoms actually appear.
What industries or situations put people at high risk for asbestosis?
Historically, high-risk occupations included those involved in the destruction, repair, or renovation of old buildings, as well as insulators, pipe fitters, boilermakers, and shipyard workers who worked extensively with asbestos-containing materials.
And what are the telltale signs on imaging?
On chest x-rays, you often see characteristic pleural plaques. These are areas of thickening or calcification on the pleura, the lining of the lungs. They are often bilateral in the mid-lung zones.
Oh, plaques.
Plaques, yes. You might also see signs of that interstitial fibrosis, the widespread sparring that can lead to honeycomb lung appearance on CT. Another classic, though less common sign, is the shaggy heart sign, where the borders of the heart look blurred because of the surrounding fibrosis.
And the major health complications associated with asbestosis are quite severe, aren't they? Beyond just the fibrosis.
They are indeed very severe. The major health effects include that widespread scarring, but also significant cancer risks. Bronchogenic carcinoma, which is lung cancer, is actually the most common cancer seen in asbestosis patients.
More common than mesothelioma.
Yes, more common overall. But mesothelioma, a cancer of the lining of the lung or abdomen, while rarer, is the cancer most specifically associated with asbestos exposure. It's almost exclusively caused by it.
That's a heavy legacy. Our journey continues now as we explore conditions with fascinating genetic links and those that stem from surprising immune reactions to everyday exposures.
Right.
Let's start with alpha-1 antitrypsin deficiency, or AATD, truly a genetic blueprint dictating lung and liver health.
Yeah, AATD is a genetic disorder where an individual's body doesn't produce enough of a protein called alpha-1 antitrypsin. This protein normally protects the lungs from damage by certain enzymes, particularly one called neutrophil elastase.
So without that protection.
Without enough of it, these enzymes can damage lung tissue, and it can lead to problems in multiple organs, not just the lungs.
What are the specific ways this deficiency impacts the lungs and also the liver? You mentioned multiple organs.
In the lungs, this deficiency commonly causes a specific type of emphysema called panasinor emphysema. It often happens at a younger age, typically before 45, which is unusual for emphysema.
Younger onset.
Exactly. And unlike typical smoking-related emphysema, which affects the upper lungs more, this type primarily affects the tiny air sacs throughout the lung, often with a basilar dominant pattern, meaning more at the bottom. It can also lead to bronchiectasis, where the airways become abnormally widened and damaged.
And the liver.
For the liver, the abnormal alpha-1 protein that is produced can get stuck and accumulate inside liver cells. This can lead to an enlarged liver, hepatomegaly, chronic hepatitis, cirrhosis, and even increases the risk of hepatocellular carcinoma, liver cancer.
Wow. Lungs and liver. Any other signs?
Some patients also develop paniculitis, which involves painful, inflamed red nodules under the skin.
How is ATD definitively diagnosed, given its varied presentation?
Well, the diagnosis is confirmed by first measuring the serum alpha-1 antitrypsin level. If it's below a certain threshold, usually around 11 micromole per liter, then genetic testing is done to confirm the specific gene mutation that causes the deficiency.
And what are the management options for ATD? Can you replace the protein?
Yes, medically, patients can receive intravenous infusions of pooled alpha-1 antitrypsin protein. This is augmentation therapy, basically supplementing what their body lacks. For severe lung disease, a lung transplantation is also a potential surgical option.
Okay. Next, we have hypersensitivity pneumonitis, or HP, which is essentially an immune system overreaction. What's the mechanism at play here within the lungs?
Right. HP is an immunologic reaction occurring within the lung tissue itself. It's important to stress it's not an infection. It's your immune system overreacting to inhaled organic agents. Things like molds, bacteria, proteins from animals, things that are natural, but your body mistakenly sees as a threat.
And the triggers for HP can be quite surprising and common, can't they? Things like moldy hay or even pet birds.
Exactly. The range of triggers is quite diverse and sometimes unexpected. For instance, moldy hay can lead to farmer's lung. Contaminated water or heating systems can cause humidifier lung.
Humidifier lung.
Yeah. Bird feces and feathers are the culprits behind bird breeder lung. And even things like moldy redwood sawdust can cause a condition called sequoiosis. It really highlights how our everyday environment can sometimes become an unexpected trigger.
Does the onset of symptoms always look the same with HP, or does it vary?
No, not at all. It can present in different ways. Acute HP has a rapid onset, typically 4 to 8 hours after a significant exposure. Feels like the flu sometimes. Subacute HP develops more gradually, over weeks or months, with ongoing lower-level exposure.
And chronic.
And chronic HP is a slow, progressive condition that develops over years of exposure, often leading to irreversible lung fibrosis, similar in some ways to IPF.
This raises an important question. What's the most crucial step in managing hypersensitivity pneumonitis?
The absolute primary treatment, the cornerstone, is the identification of the offending agent, what's causing the reaction, and critically complete avoidance of ongoing exposure. That's key.
So finding the source and removing it.
Exactly.
Yeah.
For symptomatic cases, oral glucocorticoids are often used to reduce the inflammation and help manage symptoms, especially in acute flares. But removing the trigger is the only way to potentially halt the progression long term.
We've covered so much, but we have just a few more uncommon yet crucial conditions to explore quickly. Let's talk about silofiller disease. It sounds intriguing, but clearly a hidden danger.
It is a significant and sometimes under-recognized occupational hazard. Silofiller disease is an organic dust toxic syndrome caused specifically by the inhalation of nitrogen dioxide, NO2 gas.
Nitrogen dioxide, where does that come from?
This gas is released by fermenting plant matter silage stored in agricultural silos, particularly within the first couple weeks after filling. And interestingly, smoking also increases the risk.
What happens when that nitrogen dioxide gas gets into the lungs?
Well, when you breathe in that NO2 gas, the moisture in your lungs actually converts it into nitric acid.
Nitric acid, wow.
Yeah, imagine a strong acid directly attacking the delicate tissues of your lungs. That's the kind of corrosive, damaging effect it has. It causes severe inflammation, fluid buildup, potentially long-term damage.
So prevention sounds absolutely critical here. How do workers protect themselves?
Occupational safety measures are absolutely paramount. This includes not entering recently filled silos for at least 2 weeks after they've been filled, allowing the gas levels to decrease.
And if they must go in?
If entry is absolutely necessary during that period, workers should run a blower for maybe 30 minutes beforehand and keep it running. And always use appropriate respiratory protection like N95 masks or supplied air respirators while inside.
Okay, crucial advice. Our final deep dive into the unexpected takes us from agricultural silos to our feathered friends
Yeah.
with parrot fever, also known as psittacosis. What causes this and how do people typically contract it?
Right, parrot fever or psittacosis is an infection caused by a bacterium called Chlamydophila psittaci, and despite the name, it's transmitted from infected birds, not just parrots, but also ducks, turkeys, pigeons, other fowl.
How does it jump from birds to people?
The primary way people get it is through inhalation of the organism in dried feces or respiratory secretions from these infected birds. Think about cleaning bird cages, for example, that can aerosolize the bacteria.
What are the symptoms someone might experience if they contract parrot fever? Does it feel like a cold?
It typically presents more severely than a cold, often with an abrupt onset of influenza-like symptoms, high fever, chills, severe headache, muscle aches, maybe nausea, vomiting, diarrhea.
Flu-like. Okay.
Yes, but this is often combined with symptoms of atypical pneumonia, like a persistent dry cough, shortness of breath, chest pain, and sometimes even coughing up blood, hemoptysis. All of this crucially happens in the context of bird exposure. That history is key.
Is there a specific diagnostic clue that helps doctors pinpoint psittacosis, especially since its symptoms can mimic other illnesses like the flu or other pneumonias?
Yes, there's a strong clue, clinically speaking. It should be suspected if a pneumonia is not responsive to typical beta-lactam antibiotics, things like penicillin or cephalosporins, which are common first-line treatments for many bacterial pneumonias. This resistance points towards an atypical cause like Chlamydophila.
And once it's suspected and diagnosed, what's the go-to treatment for parrot fever?
Tetracyclines, specifically doxycycline, are the first-line therapy for psittacosis. They are generally very effective.
Wow, that was truly eye-opening. What an incredible diversity of lung conditions. We've journeyed through how our bodies interact with such a complex world. I mean, from the air we breathe at work to our own genetic predispositions and even surprising sources like bird droppings in our homes.
It really underscores the intricate connections, doesn't it? Gaining knowledge about these very challenges, even briefly like this, hopefully empowers you, the listener, to better understand your own health, the importance of environmental awareness, and just the incredible resilience, yet also the vulnerability of our respiratory system.
Absolutely. It's quite humbling. So thinking about this intricate connection we've discussed between our environment, our work, our genes, what is one surprising takeaway that might change how you view your daily interactions with the world around you? Or maybe how you might advocate for your own health, or even the health of others, something to think about.